This patient is a 44 years old male patient. He came to your clinic referred by your GP. He have been involved in a road traffic accident. And since the accident, he noticed after discharge from the hospital that he had difficulty in using his shoulder and elbow. So how could you proceed with this patient?
So I would like to get a bit more history about the injury and how it was managed. Yeah. If there was any imaging available or any formal diagnosis made at the time of antecedent injury.
Yeah.
I would want to know how this is affecting his day-to-day, what his occupation is.
Okay, so the patient is a manual worker, and during his admission in the hospital, he didn't have any orthopedic management. He noticed the weakness a few weeks later after discharge, and his right hand dominant.
His right hand dominant, okay. I would want to know if there are any medical comorbidities. I would want to know the function of the shoulder prior to the injury.
He had a normal shoulder function, and he don't have any comorbidities.
Okay. I would like to further examine this patient in clinic.
Okay.
We'll do a full shoulder examination. I'll start from the neck, look for range of movement, and cursorily examine for any nerve root tension signs. Coming on to the shoulder, I would want to examine the patient from front, sides, and back. I would look for wasting, which is apparent in this case. The deltoid shoulder contour is flattened with wasting apparent in the infraspinous fossa at the back. There are no scars, any sinuses, or any previous surgical scars that I can see. The shoulder are not level, looking from the front to for the image on the left. I would want to feel for any tenderness, starting from the sternoclavicular joint, moving laterally onto the AC joint, look for any tenderness there.
So there's no tenderness.
There's no tenderness. I will palpate the lesser tuberosity bicep tendon and go posteriorly. I would ask the patient to lift their arms to the side and the front and look for scapular dyskinesia.
Okay. So the patient cannot lift his shoulder by side.
Okay. I would be concerned about the rotator cuff muscles here, and I would want to focus my examination towards those. I would show them the movements myself, and then
the patient do not have any sort of pain in his shoulder at all, and he's describing a funny sensation in his skin.
I'm sorry, you said he does not have any pain in the shoulder, and
yeah, his shoulder is pain-free. That's why they didn't spot out that there was a problem, and he described that he have funny sensation in his upper part of his upper limb, I mean, over the shoulder.
Okay. Again, this history would be slightly concerning, given the wasting that he has with the tingling that he is experiencing in the proximal arm. I would be concerned that there was probably some neurologic residual deficit from the index injury and has led to muscle wasting. Okay. Carrying on with my examination, I would show the patient the range of movement and ask them if they can mirror that, going from active assisted to passive checking of range of motion.
Okay, so passive range of motion is completely normal?
Completely normal. Okay. I would then assess for I would check for impingement, doing the Neers and Hawkins tests.
All normal.
All normal. Going ahead, I would check for abduction, checking for supraspinatus function. I'll ask the patient to lift their arm sideways.
So what's the name of this test?
It checks for abductor function and looks for supraspinatus.
Okay, how you are going to do that?
So it's the Job's test.
Okay, good.
For supraspinatus. Ask the patient to forward flex the arm about 45, so forward flex 45 and thumbs pointing downwards like emptying a can.
Yeah.
Then pressure is applied. So it's a resisted abduction essentially. Thumbs pointing downwards. I would place my my arm on the proximal to the elbow to avoid any assistance from the triceps.
Okay.
And ask the patient to
So
forward.
the patient positive jobless test.
So if this is positive, I would do an external rotation lag sign and an internal rotation lag sign, checking for. So if an external rotation lag sign is positive, that is again indicating towards a supraspinatus weakness.
Okay.
Sorry,
which one is supraspinatus?
So Job's test is positive and external rotation lag sign is positive.
So external rotation lag test is positive is indication of what?
Sorry, internal rotation lag. Internal rotation lag test.
You mentioned external rotation, which is all right, but which muscle is that?
So external rotation is caused by infraspinatus and teres minor. So
okay, that's
they're weak.
What else?
I would want to investigate this patient further. So these would hint towards a supraspinatus weakness. Given his history of trauma, I would suspect a nerve injury in this case.
Okay.
I would want to check his neurovascular status.
Okay.
So look for sensation around the regimental badge region for axillary nerve injury. Okay.
So how you are going to examine his sensation?
So light touch, crude touch, pinprick, temperature sensations.
Yeah. Which zone?
So the inferior half of the deltoid.
So the patient have, funny sensation. His feeling is weak over this area. Which area you are checking as well?
The regimental badge area. That's the inferior part of the deltoid.
Okay.
And his abductor function is weak as well with deltoid atrophy.
So we finished now with the sensation?
Yes. I would carry on with the sensations to the lateral and medial aspect of the arm.
So which nerve is that, or which?
That's the axillary nerve in the regimental badge area.
Which dermatome is that? Which nerve root?
P5.
Okay. What else?
I would again carry on looking for sensation, any alterations in C6, 7, and 8 going down the lateral aspect of the arm.
C6? Where is C6?
C6 comes from about the elbow to thumb and index finger.
Okay.
C7 is the middle finger, and C8 is ring and little finger coming up to mid forearm, and then T1 is the medial side of the arm.
So you have weakness over C6 as well.
Altered sensation over C6.
Yeah, 5 and 6.
5 and 6. I would assess biceps function.
Okay.
I would examine for elbow function as well. Look for any weakness in flexion.
Okay.
If I find something.
So it's a little bit weak.
Okay. I would carry on the examine the wrist. I just wanted to reconfirm if the examination of the cervical spine was normal.
Okay, normal.
So from the examination, this is indicative of a C5-6 lesion with apparent atrophy of the deltoid and weakness in supraspinatus. I would want to investigate this further, get an MRI scan of the shoulder as well as cervical spine. Okay,
that's fine. And so what's your provisional diagnosis?
I would suspect post-traumatic axillary nerve injury.
Okay, so the axillary nerve, what is the supply of the axillary nerve?
It supplies deltoid and teres minor.
Okay, so you have
supraspinatus nerve injury.
From your examination, which are the muscles which is weak?
So deltoid and supraspinatus.
What else?
And biceps. So it's a C5-6 injury. I would think about cervical spine, possibly cervical spine injury, and that's why I would want an MRI of the shoulder and the cervical spine.
Okay, so the patient do not have any problem in cervical spine as well. Your provisional diagnosis is, can you be more concise, because the cervical spine is completely normal?
Yeah, I would be suspecting a suprascapular nerve injury in this case.
Suprascapular. Okay, I think we can now discuss our response for your answer. What do you think you did?
I think the history and examination were fine. I was just a bit taken aback by the C6 picture?
Yeah, so the history was fine, but a little bit should be more detailed. So for the history, you should know his handedness, his job. You asked that as well, which is okay. You should know which part of his daily activity which is hindering him from doing his job. Other comorbidities, you have asked that if he's a smoker, what is his expectation? What is the patient's expectation from the management? Then family history, should ask about family history, smoking, drinking, and stuff like that. You should like have systematized way of taking the history. For the examination, again, you need to be more systematized. So I tried to give you some clues by telling you that the patient have funny sensation, which means there's something neurological, which you started to begin thinking about a neurological injury. But you should have systematized. So these patients do not have any pain. So there is no impingement sign needed. There is no subacromial bursitis, rotator cuff arthropathy. It is a differential diagnosis, but still, as the patient have neurological symptoms, you got to be focused on the neurological symptoms. When I told you also that I had funny sensation C5, C6, so probably this is upper trunk brachial plexus injury. So the way of answering this question, especially in the clinical part, you should have systematized way of answering. So you'll tell the examiner, this is a brachial plexus, upper trunk brachial plexus injury. You should answer a few questions, whether this is avulsion from the root, is it supraclavicular or infraclavicular? Okay, so you'll tell the examiner, I'm going to examine the upper limb muscles in relation to the brachial plexus. So you'll tell him, I'm going to examine the roots, the nerves coming from the roots, the trunks, nerves coming from trunks, and the cords, nerves coming from the cords, and the peripheral nerves. So in this sequence. So first of all, you are going to examine. So to make it easy for you, I will examine 3 muscles in the front, 3 muscles in the back, and the rotator cuff muscles. 3 muscles in the front. These are the deltoid, pec major, and latissimus dorsi. Okay. 3 muscles in the back, rhomboids, trapezius, and serratus anterior. Okay, and then the rotator cuff muscles. So you'll have now clue, because when you examine the pec major is normal, so it's fine. Deltoid, it is weak, so now you have a clue. The deltoid, the axillary nerve, and C5-6 is affected. Then you have latissimus dorsi normal. Okay, so it's okay. Now the cord is fine, because latissimus dorsi nerve from the posterior cord. Then you go to the back. You have the trapezius, spinal part of accessory, normal. Then you have serratus anterior. Serratus anterior, C5, 6, and 7 roots. So of course, you got to tell the examiner, how could you examine the serratus anterior, which is the sign is winging of the scapula, either by pushing on the hand or tell the patient to push on the wall. Okay. And each muscle you got, of course, to tell how to examine this muscle. Okay. So, but I'll make it briefly. So from the back, serratus anterior, if it's affected, so it's avulsion injury from the roots. If it's normal, so the level is is below the roots, so it might be in the trunk. From the back, you examine serratus anterior, trapezius, and rhomboids. Rhomboids is from the dorsoscapular nerve. Dorsoscapular nerve is from the upper trunk. And this is the clue for this case. So the patient have atrophy, as you mentioned, atrophy in the supraspinatus, infraspinatus fossa. So the patient have upper trunk, upper trunk brachial plexus injury, which is at the level of the trunk. Okay, but of course you got to complete the examination. So you'll examine the rotator cuff muscles, supraspinatus, infraspinatus. You have done this, which is good. Subscapularis, you didn't mention subscapularis. Subscapularis is normal. It's the nerve supply is from upper and lower subscapular. You have 2 tests for the subscapularis, the lift-off test and the press belly test. Okay, and a teres minor, the Hornblower test. Okay. And then you are going more distal. So go from proximal to distal. As you go distal, so examine the biceps. You mentioned the biceps. That's fine. So flexion, extension. Okay. And then 3 movement to finish your examination, to know the peripheral nerves, which is the OK sign, which is for the median nerve, cross finger for the ulnar nerve, and pointing for the radial nerve. Okay. And then you continue for the dermatomal and myotomal. Dermatomal examination, as you mentioned it correctly, that's fine. And then myotomal, if you'd like to confirm C5 abduction, C6 flexion, which is weak for the biceps, triceps, C7, and then flexion of the finger, C8, extension, C7 as well, and cross finger or interossei abduction of the index under with resistance is T1. Okay, so this is like systematized way of thinking for the examination. But don't forget, of course, to examine the patient to see his gait. So you got to examine his fascias, because if there is Horner syndrome as well. So examine the patient standing. There is Horner sign, ptosis, meiosis, and hydrosis. As you mentioned, do an MRI. This is actually the sign of avulsion, root avulsion, but not in this case. So if there is meningomycete, pseudo-meningomycete, which is avulsion of the root of the brachial plexus, it's another sign. Okay. So this is how you do chest X-ray to see if there is phrenic nerve affection. And of course, you have differential diagnosis, which you mentioned, the cervical arthropathy, cervical spondylosis, cervical disc might be one of the differential diagnoses. It might be also a ganglion in the we got to know if it's preganglionic or postganglionic. And the management, we said the nerve conduction velocity, X-ray, MRI, and then you mentioned the ladder to regain the muscle power. If you reach, I think if you reach the investigation, it will be all right. If you can reach the muscle transfer, it will be you will score high. So it's a little bit tricky. It's not an easy question, to be honest. Do you want to ask anything?
No, that was good. Thank you. I just could not think about upper trunk.
No problem.
Sorry, sir. You said you look at 3 muscles in the front, 3 muscles in the back, another 3 muscles.
No, not yeah. So rotator cuff muscles, you know them.
Right. Yeah.
So 3 muscles in the front, 3 muscles in the back, rotator cuff muscles, and probably you'll have
3 movements.
And 3 movements. Yeah. So after the rotator cuff muscles, flexion, extension, triceps, biceps, and then the 3 movement.
Yeah. Thank you.
So after you go in this systematized way, probably you'll know, is it preganglionic, postganglionic, is it supraclavicular, infraclavicular, is it root avulsion, is it trunk, is it cords? Probably you'll have a clue. But to be honest, even the clinical examination, by the way, it's about 30% accurate. But you got to show the examiner that you have systematized way of thinking, you know how to examine the muscles in relation to the nerve, that you are aware of the brachial plexus, branches, and you know what is the muscle supplied by which part of the brachial plexus. This is really very important. Okay, so we can move on. This is a 70-year-old patient who came to clinic referred from your GP. And he had difficulty in overhead activities. How would you start managing this patient?
So for me, I want to take a detailed history. I want to know what hand they use, what their job is, whether there's, and then I want to take a more detailed history of exactly what happened when this began, when they first noticed it, whether there was any associated trauma at all. The patient, he's now retired. He's doing like some sort of gardening. He's right hand dominant. The pain. He has started first with pain, like 12 months ago, and he went to the GP and he managed him with painkillers, a little bit of physiotherapy, but still is getting worse. Okay. And where exactly is the pain?
The pain is mainly just below his shoulder.
Okay. And there's no associated trauma whatsoever?
No history of trauma.
Okay, well, then I would want to do a full examination. So look, feel, move. I'm looking at the front and the back. I'm looking for any obvious deformity or muscle wasting. Move, I'm going to do both active and passive movements of the shoulder, looking particularly around the cuff and the shoulder movements and the shoulder girdle. I want to see what he can and can't do, where his arc of movement is actively, and whether I can overcome certain things passively or not. With the history I've got, my differential already is starting to lean towards either a rotator cuff tear or frozen shoulder with the information I have. So depending on what my examination finds, I would kind of go from there.
Okay. So for your clinical examination, you have done passive range of motion. Passive range of motion is or near normal, reasonable, but there is painful arc from 70 to 120. For the active range of motion is from about 30 to almost 90, as you see in the pictures.
Okay, so actually it sounds, correct me if I'm wrong, it sounds more like a frozen shoulder picture than a rotator cuff type picture. If he's stopping at about 90, but actually passively we can get him over.
Abduction, in terms of abduction, his internal rotation is normal. His external rotation is not. I mean, it's not really affected. So
okay, so sorry, so that sounds more like a rotator cuff type injury. So taking into account of that,
you have done passive range of motion, active range of motion. What other clinical signs you'd like to look after?
So I want to examine his cuff specifically. Okay. So I would want to test the kind of four muscles in the rotator cuff itself. Okay. Basically doing the Job test for supraspinatus, the external rotation lag sign for infraspinatus, hornblowers for teres, and belly press or lift off for subscap. Then for
so the signs is as the following. So his supraspinatus, infraspinatus are weak, and subscapularis is all right.
Okay, so again, it may be a partial cuff type picture, kind of either degenerative or partial tear, but it certainly sounds like he has 3 out of 4 of his cuff muscles are weak. So I'd like to get some investigations, really, if that's at all possible.
Okay. Yeah.
My first step is to get plain films. I want to see whether there's a cuff tendonitis, either calcific or otherwise. Okay. Whether there's there we go. So this is an AP radiograph of the right shoulder. The most obvious abnormalities are that his proximal humerus has migrated proximally, superiorly rather. He's got some degenerative changes in the glenoid, and it's hard to see what's going on there around the ACJ as to whether those are loose bodies or just degenerative changes. But certainly I do wonder whether this is kind of a more chronic picture of a chronic rotator cuff.
Any other investigations you'd like to?
Yeah, so if it's at all possible, an MRI would be nice as well. Okay. There we go. So I would want the MRI to be reported by a radiologist. But looking at this, again, I see there's on the left image, there appears to be some inflammation and free fluid around the humerus.
Okay. Can you appreciate the rotator cuff?
So looking at it here, it looks like it's quite degenerate. Looking superiorly, there looks to be some kind of fatty infiltration in the cuff.
You're talking about the right side picture?
Yeah.
Okay. So do you know the grading?
I don't know, sorry.
Oh, no problem. So how you are going to manage this patient? So
the treatment starts with non-operative and then escalates, if you like, to operative. So you have to take into consideration age, activity level, and the kind of the findings on scan. But nearly everyone with any kind of cuff pathology, you want to start with lifestyle modification, physical therapy, non-steroidals, and you may consider offering subacromial corticosteroid injections for symptomatic relief if the symptoms are quite severe. And you need to give them a good a good length of time to trial physiotherapy and appropriate analgesic regimes.
Okay, so for this patient, you have actually exhausted all the conservative management, have done physiotherapy. He took maybe 2 or 3 injections, steroid injection, and he's fed up, and he tells you that he wants to return to his activities and enjoy his life.
Yeah, so you've got 2 options really. You can either consider doing something with the shoulder in terms of the soft tissues, like decompression and cuff debridement. You can consider repairing the cuff, but he isn't a candidate for this. And then
he's not candidate.
Pardon?
Why he's not candidate for repair?
So it's not an acute tear. The picture, both radiographically and clinically, is a chronic tear. He is an older patient with a degenerative tear, but again, looking at these scans, there appears to be quite a bit of fatty infiltration. So the chances are that it would be unsuccessful. And yeah, the next step, especially with his x-rays, would be arthroplasty. In a patient with a cuff issue, you want to consider using a reverse shoulder, as that medializes the moment arm, so that the deltoid can do a lot of the work that the cuff used to do, and they get good outcomes.
Okay, happy with that. Okay, I think we finished this case. So what do you think you did today, Simon?
I think I was okay. I think at the beginning, I wasn't sure which way it was going, frozen shoulder or cuff wise. But once it became clear that his cuff was the issue, I think I didn't do anything unsafe. I don't think there are any particular alarm bells.
Yeah. So in my mind, you have done really well. So the history was okay. For the examination, you went through the examination of the rotator cuff. You have done a passive active range of motion. So to actually, when you are thinking about adhesive capsulitis, it's very easy to differentiate if it's adhesive capsulitis from the examination, or rotator cuff injury, or adhesive capsulitis on top of chronic rotator cuff by doing external rotation. I mean, to see if it is limited. So limited external rotation, you have only 2 diagnoses. Limited external rotation. So this is straight away. Limited external rotation of the shoulder, 2 diagnoses. First of all is adhesive capsulitis. Second is primary or whatever osteoarthritis of the shoulder. Okay. How could you differentiate? You'll do an X-ray. If the X-ray is normal, this is adhesive capsulitis. If it's not normal, it is arthritis. The third diagnosis, usually you will not get it in the exam, which is locked posterior dislocation, which is, you have limited external rotation. Maybe I will do differently the impingement test as well. Maybe I will do the near sign scarf test and hook and sign in one movement. It will give me a clue as well. But the main clinical examination is the rotator cuff examination, that to show the examiner that you do it very well, and you know why you're doing the movement, how you do it, and what is the nerve supply as well of the rotator cuff muscles. You mentioned the X-ray and MRI. My question regarding why this patient is not candidate for rotator cuff tear, you mentioned a few things which is completely right, but in this case, the first most important contraindication that the shoulder is arthritic. You have rotator arthropathy. So there is no way that that you're going to repair a rotator cuff in an arthritic shoulder, in my mind. But otherwise, I believe you are fine. It's a clear pass for me. Thank you very much. Okay.
Hey, just a quick question regarding adhesive capsulitis. Can you see obvious wasting supra and infraspinatus fossa compared to rotator cuff as well? Is that usually obvious?
I don't believe clinically you will have any muscle wasting in adhesive capsulitis. I don't think so.
Yeah, because the picture was really wasting. That's why I was thinking.
So wasting because it's a chronic rotator cuff tear.
Yeah.
And there is atrophy, and MRI also is showing fatty infiltration, which means there is atrophy of the muscles. That's why also this
that's what I mean. We can definitely exclude from the start adhesive capsulitis, or we can still put it as a differential.
No, you
can put it.
You can put it because when you going through the examination, you will know whether there's adhesive capsulitis or not by just simply doing external rotation. So you'll do during the examination passive and active range of motion. You will do external rotation. Immediately you know that it's not adhesive capsulitis. That's why when I mentioned to Simon that the patient external rotation is near normal, so immediately exclude that it's not adhesive capsulitis. So it's very simple. That's why once you have external rotation limited, to diagnose in your mind osteoarthritis and adhesive capsulitis.
So why not rotator cuff can create limited external rotation as well?
Yeah, it can, because if the secondary osteoarthritis or rotator cuff arthropathy, there will be limitation as well. But the exam, it shouldn't be that complicated, to be honest.
Thank you.
This patient came to your clinic. He had been involved in a fight, and he came to you to. So just 1 second. I'm sorry. Sorry, guys. So how you are going to manage this patient?
So I'm seeing this patient in clinic. I would want to get a proper history from him in terms of how long ago did he have this injury. Whether it was associated with
so this is a 20 years old gentleman, 48 hours involved in a fight with another person and sustained a puncture injury.
So whether he had sought any medical treatment or has he taken any antibiotic since his injury, then I will ask about his whether. So the first thing would be whether he has taken any antibiotic. Then
he didn't take any antibiotic.
Then I would ask his hand dominance, his job, whether he's a student or he's a what job he's involved in.
Office, office. He's working in an office.
Just take a brief history of his past medical history, his regular medications, and tetanus prophylaxis status. And
so what's your provisional diagnosis?
So my provisional diagnosis would be a fight bite, where he could have involvement of septic arthritis of the metacarpophalangeal joint or osteomyelitis of the metacarpal head.
How would you assess the patient?
So on this clinical picture, there is obviously an injury on his middle finger, metacarpophalangeal joint. There is roughly a 1 centimeter longitudinal wound. So I would look at whether there is any local warmth, redness, tenderness, any fluctuant swelling. Look on the volar side if there is any swelling of his flexor sheath, of his thenar, hypothenar space, mid-palmar space. Look if the wound is discharging pus. I will also look for if there is any extensor lag of his extensor tendon. So ask him to do active movement of his metacarpophalangeal joint into extension, and then assess whether there is lag.
He's not able to move his finger at all.
Okay. Only the involved finger or the rest of the fingers?
No, the involved finger.
And then also check whether his capillary refill, and also check his digital nerves. So after doing a clinical examination, then my provisional diagnosis would be a fight bite with potential extensor tendon or an extensor mechanism of injury. So I will request few investigations, mainly blood investigation, to look for his inflammatory markers and his white cell count, and also arrange an ultrasound to see if there is any extensor tendon injury. But but I would not wait for the ultrasound to be done, because it would be more of a surgical emergency. So I would discuss with the patient that is this his dominant hand?
Yeah, he's dominant.
So I would discuss with the patient that with 48 hours of injury, there is already potential that the joint is infected, and there is also possible that he has got osteomyelitis in his metacarpal head, and also tell him about the possibility of an extensor mechanism injury. So I will consent him for open washout of his metacarpophalangeal joint, and also try and repair extensor hood and extensor mechanism if there is major injury to the extensor mechanism.
Okay.
So on consent, I will tell him about the potential for ongoing infection, potential for long-term IV treatment with antibiotic, potential for recurrent visit to theater, then doing it as a stage procedure. If the joint is very infected, then extensor mechanism repair can be done at a later stage. So doing as a staged procedure, and also potential for wound healing problem and osteomyelitis. So after proper consenting him, then I will mark and take him to theater under regional block or general anesthetic with a tourniquet, position supine on the arm board. I would extend the skin incision and explore the metacarpophalangeal joint.
So are you going to start the antibiotic before the surgery?
Yes, sorry, I did ask him about the antibiotic. If he's already not on antibiotic, I would start him on depending on his allergy status. I would start him on coamoxiclav if he's not allergic to penicillin, or discuss with the refer to the local antibiotic protocol.
For the antibiotic, are you going to start before taking the swab or after taking the swab?
So give the antibiotic after taking a swab, and start antibiotic, and then after starting the antibiotic, then we can take some during procedure we can take deep samples as well.
Okay, go on. Yeah.
After open the metacarpophalangeal joint, and with that usually the capsular break will be more distal, so we have to flex the finger to actually look for if there is any capsular break, and also wash out the joint.
That's fine.
One thing I probably missed out is I did not request an X-ray, a PA and oblique, and that would be to mainly look for if there is any metacarpal head fracture, and also if there is any osteochondral fragment that I can see on X-ray.
Okay. So you found that the extensor tendon is torn. What are you going to do?
So if there is more than 50% tear of the extensor tendon, then I would proceed to repair the extensor tendon. But on closure, I would leave the capsule open, so that if so I will just repair the extensor tendon and leave the capsule open.
Okay. So I mean, there is a lot of pus and infection, and still you're going to.
So if the joint is grossly infected, and if I think that he would have to come back for a second look washout, then I would not proceed with repair of the tendon. I would debride the wound and leave it for a second look to plan a definitive surgery for the extensor mechanism.
Okay, which organism is commonly cause the infection?
So the most common infection is Staph aureus, but the most specific would be Echinella corrodens.
Okay, that's fine. Thank you very much. Okay, I think we finished. It's straightforward case. What do you think you did?
Again, whole day I was struggling with sequencing the events. So I think I should have requested the X-ray from the start rather than intraoperatively then going back and asking them.
I think you did well. Don't be harsh on yourself. You're more or less safe. You have asked for ultrasound. I'm not sure if it's important ultrasound. I think X-ray is more important, as you mentioned, but still you mentioned it. So for me, it's clear this is a fight bite. It's an you got to mention to the examiner that this is an emergency. and you proceed, as you mentioned. I got to see his tetanus status. I got to see if he's feverish and tachycardia. I got to see his general condition, if he's systematic well or not. And this is the answer of the question of, are you going to give him antibiotic or not? If the patient is systemically not well, you got to give him start antibiotic regardless of the swab. Okay. So this is the only thing which I would like to tell you. And then you do the blood tests, CBC, SAR, CRP, see if they are high. Definitely they are high. You're going to proceed and take him to the theater. You manage his tetanus prophylaxis, and then you'll start to aggressive debridement. You are going to tag the extensor tendon for a second look. For me, I will not repair it if there is infection and pus. Open the capsule, do good debridement, and then leave the wound open. And then second look after 48 hours, cover him with antibiotic, which is broad spectrum coamoxiclav, cephalosporin, metronidazole for anaerobes. I think this is the best answer for this question. Thank you very much.
Thank you. Thank you, sir.
And 78 years old male patient, he came to your clinic, filled as GP with this picture. So can you describe the deformity and tell me how you're going to manage?
The clinical photograph of both hands and wrists is showing a flexion posture of little index and middle finger of both hands. This is consistent with Dupuytren contraction. I will take a detailed history focusing on the risk factors, whether there's alcohol, diabetes, and then I will ask patient with what, whether there is pain, any function-wise, to what extent it can affect his daily life, and then when either treatment underwent so far, and then I will proceed with the clinical examination to
so the patient is mentioning that he cannot hold any stuff in his hand. He cannot release his stuff from his hand by moving his fingers, and he's struggling, really struggling. He haven't taken any medication up till now. He just referred from the GP.
Yeah. So I will then I will proceed with the examination to assess deformity for each joint, starting by each finger, isolating the MB joint, PIB, this DIB for each joint, active as well as passive. I will check the neurovascular status by including sensation as well as vascular of each finger. I will assess each cord, starting by the little finger with extensor for the.
So what are the cords?
Say again, sorry.
So what are the cords you are examining? I mean.
Yes, I will musculotendinous cord in the palm, and then I will trace it down to the PIB to check for the sural cord, and then notatory cord in between the web space between the little and the ring finger. I will assess the extensor abductor digiti minimi cord in the little finger as well.
So what's your differential diagnosis? I think we are describing, yeah. So your differential diagnosis or your diagnosis?
This mostly it is a Dupuytren contracture.
Okay.
A Dupuytren disease, which is suggesting based on the history and the clinical examination.
Yeah.
So then I will assess the cords from abductor minimi, digiti minimi, musculotendinous, sural, as well as notatory cord between the web space between the little and ring finger. I will check also whether there is commissorial cord in the web space of the thumb. Then I will assess an top table test to check whether the patient can achieve full extension or not. And then proceed with examining each finger, as I said, the active as well as passive range of motion from the MCB to the distal interphalangeal joint for each finger. And then I will discuss the case with the patient to what extent.
Do you need to do any further examination in terms of, would you like to see anything on the dorsum of the hand?
Sorry, this is also, I think there is nodules, but I'm not aware of, I don't remember the name itself.
Okay.
Gerard nodules, or I don't remember.
Yeah, Gerard's, yeah. Garrett's.
Yeah, Gerard's nodules. And then I also will check the,
Garrett's
what's
beds.
that?
Garrett's beds.
Garrett, yeah. And then I will check the, also because given it is a bilateral and will be concerned about Provisional Diagnosis,
Yeah.
we'll check the foot as well as the penis for nodules.
Okay.
And then I will discuss the treatment option with the
Anything
patients.
else in the foot you'd like to examine?
Plantar nodule neurofibromatosis or plantar
Lederhus disease. Okay.
Lederhus, yeah, sorry, Lederhus, yeah.
No problem. So do you know the etiology?
It usually proliferation of myofibroblast. The offensive cell is myofibroblast, and it usually proliferation of myofibroblast in the hand.
So we're going to discuss with the patient. So what is the options?
So the options would be do nothing. I will discuss with the patients given there is high risk of recurrence and there is significant risk of complication associated with the surgery. However, so this and treatment can be non-operative, starting by physiotherapy, which is unlikely to improve, analgesia, and depends on the patient's expectation as well as function. If he wanted to proceed further, I can offer him injection of streptokinase. However, I'm aware that it's unlikely to be existed. It started to be very rare in the market.
I mean, what are you going to do yourself? I mean,
yeah, so I will offer. So it's a bilateral. It depends on the. It is. I will utilize a shared decision with the patient with a. If he including the risks, etc. However, if he want to do something done surgically, I will discuss this case with a hand surgeon, including a plastic surgeon, to consider. So, assuming, so I will target this case, which as a dominant hand first, and then my goals are to improve the extension in the fingers. Given it is as a flexion tend to be more than like 50 or 60 degree in these fingers, I will offer this patient fasciectomy with plus minus a skin graft. Okay,
how are we going to consent the patient?
So this is, as I mentioned, this high risk of complication, including neurovascular recurrence, as well as up to amputations that could be possibly happen at the end. So I will discuss with the patient all options or all risks, including the amputation.
Okay. Can you take me through the surgical procedure?
So the surgical, I will utilize prana incision, which is zigzag type incision. And I will, the technical issues here is the neurovascular subluxation, which is potentially superficially enough, and I will be mindful of handling the neurovascular before I do any release for the cords. Then I will trace the cord, isolate them, and then I will try to close the wound with.
Where exactly will be worried during your surgical procedure?
The worry two things: neurovascular injury as well as soft tissue coverage.
where in the incision during your procedure? Where exactly
So,
you want it?
at the apex of each of the angle of the planar incision, usually the neurovascular is volarly subluxed significantly more than original or the anatomical position of the neurovascular.
That's fine. Okay, so I think we finished this question. So what do you think you did?
So I think the structure should be more, I know the topic well, but structure should be more like concise and clearer.
Yeah. So I think you did well. You took the history. You were safe. You know the codes. You know the how you're going to manage the patient. But I think you got to be a little bit more slack. So you got to know, first of all, for the examination, I'll examine local and then I'll examine systemic. So examine local, as you mentioned, the top table test, examine the angles, we'll see the pinch, we'll see the power, examine the hand as normal. And then don't forget, particularly in this case, the Allen test to determine the vascularity. So you mentioned that you are going to examine the neurovascular bundle, which is good, but be specific. Allen test is very important. This is pre-operative test, which you should also document during dictating the letter for this patient. Just a few points. Then after examining the patient, you'll tell the examiner that this is a bilateral. So as you mentioned that it is the uterine diathesis. So I would like to see if there is pioneer disease, Ledder-Host disease. I'll see the history of alcoholism. If there is a family history, there is high incidence of recurrence for these patients. Then you will go through the management. Conservative management is an option, but I think in this case it's really severe. The patient mentioned that he's suffering from doing his normal daily activities. So discuss with the patient, as you mentioned, and then you'll go for straight away. Don't mention the injection, straight away go for partial fasciectomy. Go through the consent form. You mentioned the consent form very well. Amputation is one of the complications you should tell the patient that he should be aware of. It is a possibility. Then go through the incision, and I think you mentioned the surgical approach is fine. I'll put the patient supine position, side table, put it tourniquet, and then I will do the Brunner Z-plasty. I will dissect the neurovascular bundle on both sides, dissect the cord, and I will be aware that the neurovascular bundle is pushed and at high risk of injury at the base of the finger. So this is the clue for these cases. Then post-operative, discuss the patient post-operative, bulky dressing, same as usual as your practice. Hand therapy involvement, splinting of the hand 24 hours for I think 6 weeks. So this is how you answer the question. But I think you are all right. You need just to polish it a little bit. Okay.
Thank you.
Thank you very much. So move on. Who's next? Anyone would like to answer this question? Straightforward question.
Yeah, we first has just had to step out and pick his daughter up. So if somebody wants to do, I think this is a good case to do actually. Should we do this and then we'll move on to Justin? Anybody want to do it? Or is everyone tired? Islam, do you want to do it then? Or
yeah, that's fine. So this is a clinical photograph of both hands that showing multiple deformities. I can see a Z deformity of both thumbs. There is a Boutonniere deformity in the middle finger in the right hand, potentially in the middle and ring finger. There is, sorry, I said the swan neck. I mean swan neck. And then there is a Boutonniere deformity, maybe in the ring, in the little finger of the right hand. This is suggesting features of rheumatoid hand. I will take a detailed history, ask for rheumatoid history, medication, what treatment underwent so far, what function, affection, what's the patient expectation, including diabetes, smoking. Then I will check for any and then I will proceed with the clinical examination. My exam will focus on the neurovascular status, including neurovascular status. I will assess the caput ulna for and synovitis, subluxation of the distal radioulnar joint. I will check for the radial deviation of the metacarpal with ulnar, which does look in the picture, ulnar deviation of the fingers. Then I will proceed with assessing each finger in isolation, started by the thumb, for correctability of the deformity, for either to what extent this can be corrected, for any subluxation of the tendons. I will assess.
So the patient is mainly, her concern is the thumb. So I want you to concentrate on the thumb examination and what you'd like to do for this patient.
So I will assess
the theme of this deformity.
Yeah, this is a Z deformity of the thumb.
Okay.
It is hyperextension of hyperextension of metacarpopharyngeal joint, the thumb, flexion of hyperextension of the CMC with flexion of metacarpopharyngeal joint and extension.
What is the ligament which is important for the CMC joint, and in the rheumatoid arthritis is affected and leads to subluxation of the CMC joint?
So it's ulnar collateral ligament of the thumb.
In the CMC joint, at the level of the CMC joint. Between the trapezium and the first metacarpal. Anyway, so do you know the pathology why the patient have this?
It's usually muscle tendon imbalance of the thumb with associated of degenerative changes in the joints, potential subluxation of the tendons as well, or attrition of the tendons.
Okay. Anyway, so can you describe the radiological classification for the thumb arthritis stages?
Do you mean CMC?
Yeah.
Yeah. I'm aware of 18 classification that start by widening of the CMC as a result of synovitis, okay. And then narrowing of the joint space to end up by the severe or pan-arthritic changes around the CMC.
Okay. How could you manage this patient?
So I will offer this patient trapezectomy with suspensory.
Any non-operative management?
So non-operative management is like modification of daily life, analgesia, physiotherapy, bracing. Okay. If this,
yeah. So so surgical management.
Surgical management, I will offer this patient fusion of the CMC. Trapezectomy with suspensory fixation to the base of the first metacarpal, okay. With potentially fusion of metacarpopharyngeal joint.
Okay, that's fine. Any other management options?
Tendon rebay or transfer wouldn't be an option because of the vicious circle of the disease. I think that fusion would be the best option, probably CMC and first Metatarsophalegeal joint.
Okay, that's fine. I think we finished. Okay, what do you think you did, Slan?
Not sure.
Okay, I mean, you're fine. You described the deformity. You went through the clinical examination, but I think we need to polish it a little bit. So first of all, you described it very well. I described all the deformities of the finger. We'll concentrate on the thumb. You got also to mention, so it's probably bilateral symmetrical, probably chronic inflammatory arthropathy, most probably rheumatoid, because maybe the next slide I'll show you a skin lesion with psoriasis or something, and end up with the psoriatic arthropathy rather than rheumatoid arthritis. So don't jump immediately when you see a hand with deformities that is rheumatoid arthritis, because there is many types of chronic inflammatory arthropathy. The most common is rheumatoid, but might be psoriatic arthropathy or other types of arthropathy. Okay, this is first of all. Second of all, concentrate your examination. So I'll do a local examination, and as well I'll examine general examination. For instance, I will see the rheumatoid nodules in the elbow, examine the just scanning of the shoulder and elbow as well. Then we'll go for the clinical examination. As you mentioned, there's nothing to add. For the thumb, you got to know the why the deformity. What is the ligament? So it is the palmar oblique ligament, or what we call it the peak ligament, which is the strong ligament between the trapezium and the base of the first metacarpal bone. So what happened during chronic arthropathy or rheumatoid arthropathy? There will be chronic inflammation, attenuation of the ligament will be torn. What will happen? Dorsal subluxation of the seam joint. And this will be compensated with thumb in palm. So if you see in the picture, the thumb is in the palm. Okay. So the thumb will try to increase the span by hyperextension of the metacarpophalangeal joint. So this is how it happened. First of all, palmar oblique ligament or the peak ligament attenuation. This will lead to subluxation of the CMC joint, dorsal subluxation of CMC joint, causing metacarpal adduction or thumb in palm, as in the picture. And then there will be compensatory hyperextension of the metacarpal joint for a trial of the thumb to increase the thumb span. Because if the thumb in the palm, the function of the thumb will not work. So the metacarpal try to hyperextend to gain span. Because if the thumb in palm, the function is not great. So the hand will compensate by hyperextension of the metacarpophalangeal joint to have a better thumb span. Okay, so this is the pathology. If you mention these three things,
Do you mean hyperextension of interphalangeal joint? You mean?
No, CMC joint, carpometacarpal joint.
Yeah, but I mean the compensatory flexion of.
So the CMC joint sublux dorsally.
Yeah.
When it sublux dorsally, the metacarpal will be in the palm.
Yeah.
And then when the metacarpal be in the palm, the thumb span function is not great. So metacarpophalangeal joint will try to hyperextend. So that this one will try to hyperextend to gain span.
Yeah, but the picture, sorry, I didn't get this point. Is the picture showing metacarpal is flexed?
No, it's showing hyperextension of the CMC joint. Hypersubluxation, dorsal subluxation.
Yeah, but you mentioned the metacarpophalangeal will compensate by hyperextension.
Metacarpophalangeal joint.
Yeah.
By hyperextension. Sorry, interphalangeal joint, hyperextension.
Yeah, that's what I'm saying. Yeah, okay.
Sorry.
Thank you.
Okay. So this is the main pathology, and then you'll go then you go for management. So management will be usually start with in the rheumatoid hand. Usually the most of the patients are not demanding. So you'll start with conservative. I mean, concentrate on the conservative management. Of course, you got to have MTT approach. Rheumatologist will manage the patient. You can start with oral analgesics, local steroid injection, and the last resort will be operative treatment, which will be mainly the most successful operation is our satisfactory operation in this trapezectomy. And you got to mention there is also you have trapezectomy with sling operation. There is no evidence that trapezectomy with sling operation is better than trapezectomy alone. Then you have arthroplasty, also one of the option, and fusion. But fusion usually is usual for young patient. I mean CMC joint fusion, but it's not usually a good operation in elderly patients. So this is my.
So when we fix the CMC, is that will correct the metacarpophalangeal as well as interphalangeal?
The operation is trapezectomy. Simply trapezectomy will give relief of the pain, but weak grip.
Yeah.
Just trapezectomy. Or trapezectomy sling operation. This is another.
Yeah.
Okay.
Thank you.
You're welcome. So Nikki, would like to add anything?
No, I think that was really well done. Thanks to El Hussein. I think if you get these in the exams, particularly in the clinicals, you could spend the full 5 minutes describing every single deformity.
Mm-hmm.
And I think my approach to it was always, okay, this is a clinical photograph showing said deformities of the thumbs, ulnar deviation at the MCP joint, swan neck deformities of these fingers, boutonnieres of these fingers, consistent with an inflammatory arthropathy. And then you've covered everything. And then as El Hussein says, yes, it's likely to be rheumatoid, but if they show you the elbows with psoriatic plaques or a picture of some nails with pitting in, then you'll pick that it's psoriatic instead. And then that way you get your diagnosis out, so you know what you're talking about within the first 40 seconds. So if you've got it for a short case, you can then score points with all the other things, rather than going through each finger, describing the deformity of each finger separately. I think if they want you to do that, they will take you back and ask you that. But if you say globally, there's these so many deformities affecting these joints, and then say what it is, and then you get that out there and they know that you know what you're talking about, if that makes sense.
Yeah, thank you.